year. How do you determine whether the programs incorporate the latest research and information on suicide prevention? I'm also interested to know how Congress can further help and support your efforts. With that, I want to welcome our witnesses. I look forward to their testimony. And before I introduce the panel, let me offer the ranking member, the gentlelady from California, Ms. Davis, an opportunity to make her opening remarks.
Thank you, Mr. Chairman, and I appreciate all of you being with us today. I'm very pleased that the subcommittee is continuing to work to help prevent suicides in the military. Since our last hearing, the Department of Defense and the services, with continued support from this committee and from the Congress, have worked hard to establish, to improve, and to enhance their suicide prevention programs with the goal, of course, of decreasing suicides in the military community. And I think we would all say not only just decreasing, but someday looking towards a time when it's very rare. Sadly, even with these increased efforts, this issue continues to be a difficult one to grasp, and the number of suicides continues to grow. I'm interested to hear from the Defense Suicide Prevention Office and certainly from each of the services on the changes that have been made to the programs over the past 2 years. What have we learned? What have we changed? In particular, I'm interested in hearing more about the identification of potential indicators which may lead an individual to suicide, as well as the improvements which have been made to intervention programs providing help to those in need. In the past, we know that the services have struggled. We've all struggled with how best to appeal to the friends and family of service members, to encourage them to step forward before it is too late. I believe this is still a critical link to prevention. These are the people that are around the service member the most, and we must provide them the tools necessary to identify and to intervene when possible. I certainly welcome all of you, our witnesses, and look forward to hearing from you on what has been done, what's currently being done, and where we go from here. Thank you, Mr. Chairman.
Thank you, Ms. Davis. We are joined today by an outstanding panel, and given the size of our panel and our desire to give each witness the opportunity to present his or her testimony and each member an opportunity to ask questions, respectfully remind the witnesses to summarize to the greatest extent possible the high points of your written testimony in 5 minutes. I know most of you have been here before. The lighting system will be green. At 1 minute left, it'll go yellow. When your time is up, it's at red, and I'd ask you at that point to please finish up quickly. I assure you that your written comments and statements will be made part of the hearing record. So let me welcome our panel, Dr. Franklin, Director of Suicide Prevention Office of the Secretary of Defense. Welcome. I know it's the first time in your position now before the committee. Welcome. Lieutenant General James McConville, Deputy Chief of Staff G1 for the U.S. Army. Lieutenant General Mark Ettinger, Surgeon General of the Air Force. Major General Burke Whitman, Director of Marine and Family Programs for the U.S. Marine Corps, and Rear Admiral Ann Burkhart, Director of the 21st Century Sailor Office for the U.S. Navy. Dr. Franklin, the floor is yours.
Chairman Heck, Ranking Member Davis, distinguished members of the subcommittee, thank you for the opportunity to appear before you today to discuss the current state of the department's suicide prevention efforts. Suicide prevention is an issue near and dear to my heart. I'm a daughter of a 22-year career Navy enlisted sailor. I married an Air Force officer, and I've spent the last 20 years of my career working at various levels as a social worker with military families around the world. I've seen firsthand the trauma and devastating effects suicide has on families, friends, units, communities across the military. Previously, as a headquarters level policy lead in the area of suicide prevention in the Marine Corps, I worked diligently with commanders, chaplains, medical, and non-medical helping professionals to reduce the number of suicides in the Corps. During this experience, I realized 3 important things. First, suicide is absolutely preventable. Second, suicide is such a complex issue that the reduction of suicide across the services is possible only through active and at times intensive collaboration with a wide variety of stakeholders. And third, the risk and protective factors are common across many of the challenges that service members face. When I train my staff as a licensed social worker, I always share how clients don't typically present to us with just one problem. They come to us and other helping professionals with a wide variety of problems, including financial, legal, relationship concerns. Some are contemplating suicide, and we have to know the signs and how to get them to help. Therefore, I stress that it is imperative that we approach the problems of our clients in an integrated, vice stovepipe fashion, engaging across interdisciplinary approaches as needed. It is with this view and background that I eagerly accepted the job as the director of the Defense Suicide Prevention Office in February 2015. When I accepted this challenging assignment, the department had just adopted the 2012 National Strategy for Suicide Prevention and was developing a defense strategy consistent with this national approach. This was encouraging, as these strategy documents are central to providing service delivery that's integrated in the fashion that I previously alluded. Once on board, I conducted an internal assessment of the office, responsibilities, mission, vision, functions. Parallel to that effort, I conducted a series of listening sessions with the services and other key stakeholders and partners, to include the Department of Veterans Affairs. And my immediate takeaway was that despite the adoption of this national strategy, the DoD suicide prevention paradigm and DISPO's functions were still largely organized around that 2010 task force report. I realized the DoD strategic paradigm and DISPO's organizational structure had to shift in order to execute the office's responsibilities to support this new strategy and facilitate collaboration with so many stakeholders. With this understanding of necessary changes, my immediate actions were to order a closeout of the task force report recommendations, which is near completion. Also, to adopt an underlying theory base drawn from the Institute of Medicine's prevention continuum, and to move the department strategy staffing forward, thanks to the constructive inputs from the services and the components, and to begin the development of a Department of Defense instruction that clearly spells out the policy, the responsibilities, the procedures, and lastly, to develop an office approach, an organizational structure that could more efficiently implement this new strategy. In my oversight responsibility, one of the main efforts of the office is to identify and leverage best practices across the services, thus ensuring rigorous science in all that we do. To best implement the department's strategy, I've leveraged a public health framework in organizing DISPO along 5 lines of effort, including data and surveillance, assessment, advocacy, policy, outreach, and education. While each of these are explained in detail in my written testimony, the data and surveillance efforts will be critically important to inform the other lines of effort. During the year 2013, according to our quarterly data reports, we know that across the department, including reserve and guard components, we sadly experienced 474 deaths to suicide. During 2014, we experienced 442 deaths to suicide. You'll hear more about the trends associated with these tragic losses from my service counterparts today. In closing, I want to inform you that the department has recently strengthened our long-standing relationship with the VA. We have already collaborated on the awareness of the military crisis line, as well as a database for advanced data and analytics across both departments. And finally, an innovative campaign strategy driven by the research called The Power of One that focuses on service members, families, civilians, offering one small gesture and one act of kindness for anyone at risk. Beyond the VA and the services, I recognize the department will not prevent suicide alone. I continue to work diligently with the academic sector, with the private sector, with the National Action Alliance, and key agencies such as the American Association of Suicidology to forge the necessary long-term relationships to prevent suicide. And I thank you so much for inviting me, and I look forward to your questions today.
Thank you, Dr. Franklin. Colonel McConville.
Chairman Heck, Ranking Member Davis, and distinguished members of the committee, thank you for giving us the opportunity to speak before you on this very important topic. I'm going to go ahead and highlight a couple of points from my testimony. When I was a commanding general in the 101st Airborne Division, a Gold Star mother who had lost one son in combat and one son to suicide came to the division and spoke to the spouses about suicides. And the one point that she wanted us to take away was that people don't commit suicide, they die of suicide. And when you think about that, people don't commit heart disease, they die of heart disease. There's no stigma attached to going to see a doctor for heart disease. There's also risk factors associated with heart disease, like high cholesterol, smoking, not exercising, and eating unhealthy food. And for our soldiers, identifying and managing these risks can help reduce the possibility of dying of heart disease. We think the same thing needs to be done with suicide. There are certain risk factors that we know, and we'll talk a little about them, that put soldiers at high risk. And it's very important we identify these, and this is why I'm a very big proponent of one of our best practices that we've put into the Army, which is embedded behavioral health at every single brigade level, so when they identify the issues, they can get soldiers to the health they need. You know, the Army's had a reduction in suicides in 2014, and that was mainly due to the reserve and the guards. And as the chairman said, this year We're at about the same level for the active, but we have seen a rise in both our Guard and Reserve, and we are very concerned about that, and we're presently doing that analysis. But we are making progress in combating suicide, and it's really a multidisciplinary, holistic approach. And you talked about getting the soldiers. To us, it's absolutely key that we get the soldiers' family, their buddy, and the junior leaders involved in getting after suicides. We bring 120,000 soldiers into the Army every single year. They come from outside, and where we're going to identify the issues, it's the soldiers' family members who will be the first ones to notice whether they have behavioral health issues, alcohol and drug abuse issues, financial problems, relations problems, all those risk factors for suicide. And the key leaders is that squad leader, that junior leader who's down there with these new soldiers who can help identify the risk factors and get these soldiers to the behavioral health at the appropriate level early on before they spiral out of control. We're training our total force, not just soldiers, but also civilians and family members, and all the Army's components to get after not only suicide prevention, but resilient skills that will make them strong in the face of adversity. We've increased our access to behavioral health care services. We're also fighting suicides through research. I know many of you are very familiar with the Army STARS program, and that's helping us get the best and brightest individuals after this problem. Historically, Army medicine has found answers to some of our toughest medical problems, including yellow fever, malaria, and life-threatening infections. I'm confident, working with these great partners, that they'll do the same here. We have good policy, which we can improve. We've got programs we can do better at. But most importantly, we have exceptional leaders in the Army at all levels who are committed to taking care of our soldiers. My wife and I have 3 children serving in the Army. One just was commissioned as a social worker. And my wife expects, that all mothers do, for us to take care of those soldiers, their sons and daughters, who are serving their country during a time of war, and we will do that. I thank all of you for your continued support in sustaining a professional all-volunteer Army, and I look forward to your questions.
Chairman Heck, Ranking Member Davis, and distinguished members of the committee, thank you for the opportunity to appear before you on behalf of the men and women of America's Air Force. The United States Air Force defends our nation with a broad range of capabilities made possible by an incredible force of professional airmen, which include members of the active component, Air National Guard, Air Force Reserve, and civilians in government service. Secretary James, General Welsh, and leadership at every level of our Air Force are committed to the development of strong, resilient airmen and to coordinated, robust support as they confront problems inherent to life and mission. The Air Force strategy for suicide prevention focuses on resilience among airmen, coupled with community-based public health approach to prevention and timely intervention with follow-up for those in distress. The Air Force leadership is very concerned about the increasing rate of suicides among airmen, a trend within the active force. Last year, 62 active duty airmen took their lives, a rate of 19 per 100,000. To date, in 2015, that trend has persisted. Suicide rates in the reserve component and among government civilians have remained relatively static, but we are committed to prevention across the total force. The Air Force Suicide Prevention Program is an integrated network of policy, process, and education that focuses on fostering strong, resilient airmen, providing assistance through stressful circumstances and focused support for those in distress. In 2015, the Air Force changed its format for annual suicide prevention training to live small group discussions. Special vignettes and discussion guides have been developed for active duty and reserve component personnel, as well as DoD civilian employees, to address their different demographics and circumstances. This training emphasizes early intervention, risk factors, and warning signs to enable airmen to respond using the Ask, Care, Escort, or ACE model. The Air Force has also fielded an annual refresher course for frontline supervisors in career fields with the highest incidence of suicide. In 2014, we updated the Airman's Guide to Assisting Personnel in Distress to help commanders and other leaders on effective intervention for an array of challenging problems. This year, we also released the Air Force Family Members Guide to Suicide Prevention and trained over 200 family members as resilience training assistants. Since 2012, the Air Force has embedded mental health providers in operational units where performance demands and operational stress are concerns. Mental health providers have also been placed in all Air Force primary care clinics, allowing quick access for airmen and their families, as well as reducing concerns about stigma. We are on schedule to complete our 25% increase in active duty mental health positions by 2016. We know the importance of effective identification and treatment and controlling the impact of PTSD on airmen and families. To address this, we continue to screen airmen for PTSD symptoms via pre- and post-deployment health assessments at various points through the deployment cycle. Effective treatment has enabled the majority of airmen diagnosed with PTSD to continue serving. In addition, in 2010, the Air Force established the Deployment Transition Center at Ramstein Air Base, Germany. This center offers a 4-day reintegration program for airmen returning from deployment that involved activities associated with post-traumatic stress. Our mental health providers are trained in current and evidence-based treatments. The Air Force is also committed to reducing suicides within the clinical setting by incorporating the latest research and innovative initiatives in our mental health clinics to better manage our highest-risk patients. Improvement rarely happens in a silo, so we are actively engaged with the Defense Suicide Prevention Office in helping to shape suicide prevention efforts across DoD through multiple committees and working groups. In April 2015, General Welsh initiated a comprehensive review of Air Force suicide prevention to include an Air Force Suicide Prevention Summit, which occurred last month. Our aim is to verify factors underlying Air Force suicides, review the latest evidence regarding effective prevention, gain insight into the experience of other organizations, refresh the Air Force strategy, and identify new actions to effectively prevent suicide. Recommendations from the review and summit are now being used to refresh the strategy and build action plans. The Air Force is committed at every level to develop and support total force airmen as resilient, mutually supportive professionals. We need every airman across the total force, including those in uniform and our government civilians. We will continue to work closely with our colleagues in the services, DoD, and other governmental agencies, and in academia in this essential effort. Thank you for your attention to this important matter and your continued support.
Okay, so that was the bell. My intention is to complete testimony, and then we'll recess and come back for questions. So, General Whitman.
Thank you, Chairman Heck, Ranking Member Davis, and distinguished members. I'm grateful for the opportunity on behalf of the United States Marine Corps to update you on our suicide prevention efforts. This is an institutional priority. It's also a personal priority for me. I had a friend, colleague, and fellow officer of Marines who took his own life in 2012. Whenever a Marine chooses to end his or her own life, we're all devastated, and we ask ourselves why. Is there something we could have done? Are there actions we can take to prevent the next suicide? And we believe the answer is yes. We can take some actions in 3 different areas. We can identify the risk earlier, we can intervene earlier, and we can provide robust, ongoing support. Together, the Department of Defense and the Marine Corps have developed programs to help us do just that, to identify early, intervene early, and provide robust support more effectively than we could in the past, and with initiatives even in the last couple of years since the most recent hearing here on this topic with you. The key to leveraging these programs is human engagement by leaders, by peers, and by families. Leaders at every level are trained, prepared, and engaged with our Marines. This includes each Marine's immediate leader, whose sacred responsibility is to know that Marine. Peers who already know each other are also trained to identify and intervene early. Marines are a close-knit family. They tend to understand they have an inherent responsibility to look after each other. Equally important are family members who may witness concerns before we do. Leaders, peers, and family members can leverage the programs and the training that your Department of Defense and Marine Corps developed as tools to help prevent the next suicide. Let me offer just a small sampling of some of the more recent program initiatives that help us identify early and intervene early and provide that support. And then I'll tell you a brief recent story in which Marines leveraged those programs to save a life. Identifying a Marine at risk for suicide can be challenging because no single indicator can predict if someone is at risk. So we've taken a holistic approach to this, and we use all of our behavioral health skills to address the challenge. We know that Marines contemplating suicide often find themselves in a place of hopelessness, involving a mix of stress factors, ranging from relationship problems to financial distress. So we train all our Marines to respond to stress and peers. To help identify the risk, family members and Marines are trained to help identify Marines and to seek help. To assess the risk, once we've identified some indication, we've introduced the evidence-based Columbia Suicide Severity Rating Scale across the entire Marine Corps to include our behavioral health providers, chaplains, legal assistants, financial counselors, and others. To intervene early and provide that ongoing support, among the things we've done, we've added a community counseling program that enhances access to care by assisting Marines and families in navigating the many resources available for behavioral health issues. They can receive immediate support regardless of which door they have entered to get help. In addition, our Marine Intercept program, MIP, interrupts the potential path to suicide by providing timely intervention and ongoing support, enhancing our ability to conduct ongoing risk assessment, evolve the safety plans for the at-risk Marine, and coordinate his or her care. These are but a few, and maybe we'll have a chance to talk about some others. Let me quickly tell you about the story about one Marine from just a month ago. His trained leaders and peers had correctly identified him as being at risk for suicide due to several factors. Typically, we have 10 to 20 involved, and he was one of those. He entered the Marine Intercept program, and the Marines continued to be watchful. One day, when he was not at his expected place of duty on time, his non-commissioned officer leader immediately launched a search in the right places because they knew him. They found him hanging from a rope, but they found him in time. He was still alive, so they revived him. They rushed him to the hospital, and that Marine is alive today. We're taking care of him. He's receiving support, but he is alive. So we have some successes. We're making some progress, but Mr. Chairman, as you said, this is difficult work. We must remain vigilant. We must continue with the department to analyze the data regarding suicides, seek effective new approaches based on evidence-based research and empirical tools, continuously enhance our training and resources that we make available to our leaders, Marines, and their families toward what works. I thank the subcommittee for supporting this work, and I'll be happy to answer questions later. Thank you.
Chairman Heck, Ranking Member Davis, and distinguished members of the subcommittee, thank you for the opportunity to present you information on the Navy's suicide prevention program. Every suicide is a tragedy, and a single life lost is definitely one too many. Sadly, in 2013, the Navy experienced the loss of 46 shipmates through suicide. Although this was a decrease of 20 suicide deaths from the previous year, in 2014, we saw an increase in our suicide total with 68 deaths. For 2015, thus far, we've lost 44 shipmates to suicide. Suicide is complex, and as such, it is difficult to draw conclusions from numbers alone. We continue to monitor the health of the force and investigate every suicide and suicide attempt. The suicide prevention team examines each case for pertinent information that might inform our prevention program. Results from these reviews consistently reveal that demographic distribution of suicide largely mirrors the Navy demographics, and suicides typically occur when sailors are experiencing some combination of multiple recent stressors, including intimate relationship problems, loss, recent career transitions, disciplinary or legal issues, work problems, and financial strain. The 21st Century Sailor Office stood up shortly after the 2013 hearing, facilitating an integrated approach to total sailor fitness and resilience. The office encompasses diverse elements that impact sailors' physical and psychological health. Promoting comprehensive wellness is one of our core strategies to proactively prevent destructive behaviors that can ultimately increase suicide risk. Our efforts are focused on education and awareness, prevention and intervention, sailor care, and crisis response. To that end, since 2013, we have launched several key initiatives. We've expanded our operational stress control mobile training teams, providing training to enable deck plate and senior leaders to better assess and mitigate stress in their units. In 2014, we mandated this training for all units 6 months prior to their scheduled deployment. We've also assigned deployed resilience counselors to our aircraft carriers and large deck amphibious assault ships, working alongside chaplains, behavioral psychologists, and medical professionals who proactively assist our sailors on a daily basis. We've also implemented several key evidence-based suicide prevention and intervention measures, including training on the use of the Columbia Suicide Severity Rating Scale and the Veterans Affairs Safety Plan to enhance risk assessment and intervention at the deck plate. We'll also release guidance for commanders and health professionals to reduce access to commonly used lethal means of suicide through the voluntary storage of privately owned firearms. In 2014, we launched our Every Sailor, Every Day campaign to promote ongoing and active engagement, peer support, and bystander intervention so that no sailor feels alone. This campaign places strong emphasis on daily interaction to not only build trust and foster hope, but enable that early recognition of warning signs and get sailors the help they need. During the 2015 Suicide Prevention Month, we introduced a new message to this campaign, One Small Act. This message encouraged simple actions to make a difference and perhaps save a life. It's based on the Navy's Ask, Care, Treat bystander intervention model and the Navy's supporting the DoD and Veterans Affairs Power of One concept. We have also released an improved suicide prevention general military training, which is interactive, scenario-based, and designed to generate dialogue about stress navigation, suicide prevention, intervention, and also crisis response. Suicide prevention is about taking care of people. Navy's commitment is to provide sailors and their families the tools they need to thrive during and beyond their Navy careers. Thank you, and I look forward to answering any questions you may have.
Again, I thank the panelists for keeping their testimony within 5 minutes. I think that's a record for everyone doing so. We will recess and return right after votes. I ask the members to return as quickly as possible.
Sound check. 1, 2, 3, 4. Sound check. Good. Sound check. 1, 2, 3.
We will reconvene the hearing. Again, I thank the panelists for their testimony. We'll now begin questions from the members of the committee. Reminding the committee members that will adhere to the 5-minute rule, and if there's time remaining after the first round, we'll go with the second round of questions. So, Dr. Franklin, in your testimony, you talk about the rate of suicide among the active and reserve components. And the question is, how does the DoD actually calculate the rate of suicide, and how do the current military suicide rates compare with the civilian rates? We hear a lot of emphasis, and rightfully so, on the number of suicides within the military. And perhaps it's because it's a much more closed, basically, society with a lot of oversight and opportunity to intervene. But do the rates within the military different all that significantly from what we see in the general population?
Thank you so much for that question. I'll go ahead and start with the latter part. Typically, I try to sway folks away from comparing the military rates to the civilian rates for a number of reasons, some of which you just mentioned. But the military as a whole, largely a healthy population, largely covered by health care. When you compare demographically across the civilian population, we're looking at folks that have no health care, perhaps they're homeless, unemployment rates. There's all sorts of factors that make the two populations drastically different. On the other hand, also the military has additional stressors in some cases. I'm actually looking at this a little bit further to see if I can find a demographically similar characteristic or population. What I want to make sure we don't do is just compare a CDC data set across gender and age and think that we have a one-for-one comparison with the military, because we don't.
Great.
So that's a sticky wicket, but certainly I can understand why folks want to ask the question, looking at whether or not we should look at comparisons across the university sectors perhaps, or other types of demographics like perhaps first responders, and trying to dig deeper so that I can find a good comparison group. But the other question that you asked me was about the rate calculation. The rate calculation recently changed, and we're looking at the total force. We work with the Defense Manpower Data Center to get the denominator, and then from there we'll take the total number of suicides, and it's just a math equation where we'll divide the two, and that's how we calculate the rate.
So you say the rate recently changed. How was it calculated previously?
Before there, we would separate it out, and so now we're looking at more of the total force.
Okay. All right, thank you. And General McConville, I appreciated your analogy and the fact that you used the phrase die from suicide, not commit suicide, and the analogy you made with heart disease. And you mentioned one of the issues that we find is the stigma associated with seeking behavioral health assistance, and folks concerned that somehow if their chain of command learns about it, or it's going to impact their eval, may impact their future promotions. So I would ask each one of the panelists, what's being done within your service to try to remove the stigma of reaching out for help so that we can get ahead of this problem as opposed to being reactive?
Well, sir, thank you for that question, because as a former commander, that's why we started to think about it in a different way. We have to change the culture when how we look at suicides, because it's just like heart disease. And so what I found very helpful, in really the Army as an institution is propagating, is if you have problems with mental health, it's the same thing as having some type of heart disease, and you need to go to the right doctor. So you identify those type issues, and again, I talked to you about being a proponent for the embedded behavioral health. Having that as close to the point of need that we can get behavioral health is really very, very important. So in the way that works in a division, that brigade combat team has a multidisciplinary team that actually sits there that does physical fitness with the unit that is there. So if a soldier starts to have problems, we can get them in early on. I use the analogy even with heart disease. If you wait, and I'm not a doctor, so with the doctors here, I make it up anyways. But if you wait till you're 95%, clogged, and you go to the doctor, they may not be able to help you. But if you get them early on when you're starting to have high cholesterol and you're starting with these risk factors, and you get them to see the doctor, they can get you on the appropriate diet, they can get you to stop smoking, you can do those type things. We need to do the same thing with suicide. Someone's starting to have a problem. And the ranking brought that up about the family members is absolutely key. They're the ones that know. I've looked at a lot of suicides over the years, and people go, no one knew. Well, someone did know. And usually when you peel it back and you take a look at it, there was a buddy that knew or a family member knew. If we got it early on, we could have got the help they needed, and we might have saved a life.
Great. My time's about to expire, so I'll come back on the second round and follow up. Ms. Davis?
Thank you, Mr. Chairman. And I actually was going to ask all of you about perhaps one incident or story that you go back to, every day when you come to work, thinking about either a success story or one that was tragic. And I think, several of you mentioned that, but I guess I would wonder what that is. It's always helpful to have a family member at a hearing like this, or someone who has sort of really been there. And I have a feeling that you've lived through that, through the folks, but I wondered if you wanted to share that and what it's done in terms of your own drive to make sure that we are able to address this.
I'll go ahead and start. I guess, I have many examples, having commanded a very large organization in combat over the last couple of years. But one of the things that we did at Fort Campbell is we used to do a Mother's Day brunch for all the Gold Star mothers and family members the week before Mother's Day. And we invite all the Gold Star family members. And it was interesting who used to come as part of our Survivors Outreach. And we had people come that had lost their sons and daughters to suicide. And one man in particular came. And it's amazing the pain that father was going through, the fact that he had lost his son to suicide. And he came to Fort Campbell because there was a good program there. His son wasn't even in the division, but we had this great survivor outreach person, Susie Yates, that took incredibly care of these families. And he came to that brunch and you could see the pain. And it's a very, very different pain what parents go through with a suicide than, soldiers. I've lost soldiers in combat, I've lost soldiers in accidents, I've lost them. But that suicide, first of all, it's the end of the world for the parents. And it's a gaping hole to units when you see what happens when you have a suicide in a unit, because everyone wants to wonder what we could have done. Mm-hmm. And so you can feel my passion about this stuff. And, I have thought through this stuff, and it's getting after what we do to take care of soldiers. So every day I wake up, we have a sacred obligation to take care of the sons and daughters that parents set us. And the last thing we want to do is to have a son or daughter die of suicide. And that's a sacred obligation for us.
Mm-hmm. The story I always think back to is early in my career when I was a squadron flight surgeon for a fighter squadron in the Air Force. We lost a lieutenant young fighter pilot to suicide, and married with a child on the way. And the thing that struck me about that was that it was really a somewhat impulsive act in that case, and that he was confronted with an acute situation, a problem that was really, when you looked at it, completely solvable. And so, and then I saw the rippling effect of that tragedy as it went out to the family, and a child that was born without a father. And that really struck me that we really have a responsibility to help, particularly our youngest members in the military, arrive at a more functional approach to problems and how they approach problems, solve problems, and that we need to do a better job of connecting them with sources of help in terms of just their basic life skills, so that their approach to problems like that don't turn into a tragedy.
Mr. Chairman, the Marine Corps tracks and studies every one of the suicides and attempts and ideations that we have, and we study them and pull from them what we can. Each of us, I'm sure, has our own personal most devastating story. Mine would be the friend I lost in 2012. There's no question. He was a very close friend. But we look at all these. We looked at them in 8-day reports, and the entire institution does. The Assistant Commandant of the Marine Corps gets those reports. We review them together. If someone has survived, if it's an attempt or an ideation, the commanders get involved through our Marine Intercept program and evaluate what the problem is. We pull data out of that as well. And then finally, we have a regular institutional effort, an Executive Force Preservation Board that's led by our Assistant Commandant, that looks at all the cases in aggregate and tries to pull the lessons that we can from those to prevent the next one.
For me, I I'm passionate about people, and I strongly believe that every life is worth living, and it's really sad when I see the sit reps that come in, and I think about those lives that we've lost and the family members and the units impacted. And the Navy's committed to helping our young people and all our servicemen and women and their families understand how to better identify those risks and refer people to help and make sure that everyone has a chance to live life fully and really thrive in our environment.
Ms. Hongus?
Thank you all for being here. I can tell you that this is an issue that really strikes home with my constituents as they read the alarming statistics and stories, or if they've been personally impacted by a family member or friend who served in the military. So I appreciate all the work that each of the services has done and that the DOD has done as well. But I really want to ask a question about, and you've all certainly given great testimony to the efforts that the services are doing, but investing in. But I really want to address the issue of how you all are working together with each other and with the DOD. So on September 30th, 2015, the DOD Office of the Inspector General issued a report that states that, quote, DOD lacked a clearly defined governance structure and alignment of responsibilities for the Defense Suicide Prevention Program, unquote. And that report also states that the DOD, quote, did not standardize best practices across the department, and the services did not take advantages of each other's knowledge and experience, unquote. And I know that this is often not unique to suicide prevention. We hear that often in other contexts as well, that you work within your own service and not always across services. So I'd like first Dr. Franklin to address what changes are being made to address these issues, and also if each of you could comment upon how you share best practices and work across the services. So start with you, Dr. Franklin.
Sure, certainly. Thank you so much for the question. Make no mistake, the DoD IG absolutely cited the number of the things that you spoke about, the policy, the evidence-based practices, the research, all of it needs to be coordinated, and we absolutely needed a strategic approach. I will tell you, I think the department was largely operating in a reactive mode early on in the suicide arena as a result of the Department of Defense task force. And so by reactive, I mean they were chasing down those task force recommendations, 76 of them, and they were trying to get current. Upon completion of that, like many programs, it was an opportunity to take a pause and look at the program and look at the national landscape in the area of suicide prevention, and then determine our own strategy, moving away from task force recommendation mode to a science-based approach based on our current needs and the state of the program. So when I arrived in the office and I did a series of listening sessions with the services, we right away changed our practices. I couldn't be more pleased to tell you that the services meet on a quarterly basis. Their suicide prevention program managers, we've had 2 of those meetings so far. They're 2-day meetings. They share a number of best practices. I could give you examples, and you heard in some of their testimony where some of them are implementing similar tools like the Columbia Suicide Severity Scale or the VA safety planning. They learn that from each other, and those are exciting opportunities, and I absolutely see that as the future of the office. I'm a social scientist by trade, and I think that we need to leverage the research and we need to work together, and I'm eager to see the future of this team when we can have more time and place to execute many of these evidence-based approaches.
Can each of you give an example where you learned a best practice from perhaps the DOD or from each other?
Well, as I know there's coordination. As from where I sit, I know that we meet at the program manager level. What I'm surprised to see is as you listen to the testimony is how the concepts, especially I look at my Marine colleague here, is we're pretty much moving towards getting after the problem the same way. We understand in combat type units that these new soldiers coming in that are most susceptible, getting the leadership, getting the families. We've shared the STAR studies that we've worked with that show, which we've all spent a lot of money on, what type of indicators, and as I listen to testimony, I see many of our colleagues using that same type of information, and as we pass the information back and forth, for me, it kind of gives an idea that, hey, we're all getting after the same thing. I did an exchange with the Japanese, which is kind of interesting. We talked about sharing suicide information. Their concept is very similar to what we're trying to do. They have a one company, one floor concept, and it gets around to this whole relationship, which my Marine Corps colleague talked about, is how we make sure people are taking care of each other and identifying those risk factors. So I see the risk factors the same across each and every one of us. Thank you.
General.
A couple of examples I'll add is we are sharing the data from our research, and I know we've learned a lot from watching and studying the Army's STARS data in terms of resilience and the ability to measure that and predict certain outcomes. I mentioned our Suicide Prevention Summit in the Air Force that occurred 3 weeks ago, and Dr. Franklin was a prominent participant in that. But also the Marines were there and gave some excellent presentations in terms of their programs, and actually we're borrowing significantly from what the Marines are doing and what we're doing now, what we're implementing now.
I've run out of time, but thank you.
Mr. MacArthur?
Thank you, Mr. Chairman. I am sorry I missed your opening remarks. I was at another hearing, but I read the memo, the advance memo, and I just had a few things that maybe you've covered already. I don't know. At first, there's nothing more tragic than young people. Often, these are the people we want to be the next greatest generation, and we see so much that they have to live for, and obviously sometimes they don't. You mentioned, Dr. Franklin, that it's a closed system, the military. I think that was your word, or maybe that was the chairman's words, but you suggested you can't really compare military suicide rates with civilian rates. I think the chairman called it a closed system, but same idea. So I'm interested in comparisons within that system. And the years of numbers that I see here cover 4 years. And I just wondered if you apply this new methodology of calculating the rate, and I gathered it's currently done against total force. I'm not sure what it was, what you looked at previously. You could tell me that. But if you applied this current methodology going back 10 or 15 years, have you done that, and what does it show about the trending of suicide within the military? Is it going up, down, staying the same? Give me some sense of the magnitude of direction.
Sure, certainly. Thank you so much for the question. I would need to get back to you on whether or not we took the current methodology and traced it back 10 or 15 years. The difference between the two methodologies are that one looks at the total force and the other sort of separated out. But that is certainly something that we could do and get back to you. Overall, when I look at the numbers, I see a lot of fluctuation. There are times where you'll see that it will spike, and then you'll try to study it and understand it. It's a 1-year spike or a 2-year spike, and then you'll see where it's dipped slightly, or it's gone up at a way that it's not statistically significant yet. And so it's just this up and down fluctuation over time. Either way, it's too many. We say one is too many, and continue to study the data, not only in the context of the quantitative numbers, but also some of my colleagues today talked about the qualitative stories. Studying the full review of each and every one of these cases is critically important. They're not just a number, and we must know the names, the faces, and the stories, the risks, the protective factors, what was behind each and every one of them.
I'd appreciate it if you could get back to us. I think it could be helpful to look at trends over time, because perhaps there's some factors that are at play with conflicts that they're in, or different things where you see elevated or depressed rates of suicide.
Yes, certainly. Over time, we talk a lot about relationship issues being at the heart of a lot of this, but financial struggles, legal struggles, and also just this notion of, particularly within the military environment, sort of a falling from glory, or no longer feeling a sense of belongingness with the unit or with the military, but certainly continuing to study those risk factors. And I would also turn it over to my Army colleague, may have more to say here about the identified trends specific to the Army.
Yes, sir. I could talk a little, and again, I can't break down the numbers. I just have the statistics really for the Army as we look at different types of mortality, whether it's accidents, natural, suicide, or homicide. But basically what we see is in the Army compared to the civilian population is in 2005, we were below the numbers. We were basically at a rate of about 13, which was in the U.S. was running about 18. And then as we went from 2005 to 2012, it began to grow. And during that period of time, the Army actually crossed the civilian average. Now it's come back down to where we are a little higher, but again, I'm not a statistician, but they would say that's within the normal. So when we look at the death rate within the Army, what we find is, as far as accidents, it's much lower than our civilian counterparts. We talk about natural, much lower than our civilian counterparts. Suicides are a little higher, but again, the statisticians say that's about the same. It was statistically higher in 2012, and then for homicides, it's much lower than the rate. So that's kind of how it breaks out, and I'm not smart enough on the analysis how they get all those numbers.
I yield back.
Mr. O'Rourke?
Thank you, Mr. Chairman. I wanted to follow up on some questions asked by my colleagues, Ms. Songas and Mr. MacArthur. One of the conclusions of the Inspector General's report is that we don't have good or consistent measures for success. And so I would love to get your advice, Dr. Franklin, for this oversight committee on how we can best gauge the job that you're doing and that the different branches are doing in preventing suicide.
Thank you. Thank you so much for the question. And measuring suicide is difficult, but it's not impossible, and we absolutely owe you that, and we need to do that. When I arrived in the office, we started a refreshed effort in the context of our measures of effectiveness work. Early on, I think we were trying to bite off more than we could chew and attach measures of effectiveness to every single program out there, and now we've streamlined our approach, and we're looking at key indicators that we can collect from the chaplains, from the medical community, and then directly from the services that get after it. It's a much more streamlined, simple approach. We've developed a series of logic models to study the outcomes of the suicide prevention program as a whole, vice the individual parts and pieces that make it up. So I certainly pleased to share those models with you. It's definitely an important issue. Measures of effectiveness should be part of everything we do, and we shouldn't think of it as an afterthought, but rather part of the front end of programming.
One of the things that I think is cited as a success story in the IG report, and you mentioned it, I believe, in your opening testimony, is the data that you are collecting now. And you implied data across service, and then as the service member transitions out and becomes a veteran. And you mentioned the analytics that you're doing, the advanced analytics that you're doing on that data. Can you give us an idea of what it is that you're measuring? And I appreciate the focus on ensuring that we're sharing best practices across service branches. How are we sharing with the VA and vice versa? Because I think all of us here are also very concerned with veteran suicides as well. And so, whether it's the risk factors that General McConville brought up earlier that are identifiable, I want to know if those are being shared with VA providers and clinicians, and what kind of impact we're having there.
Yes, two-part question. The first, I think you're getting after this suicide data repository. This is a massive database, a data set that pulls together about 22 other data sets, drawn off of the CDC and the National Death Index data. It's a joint partnership between the Department of Defense and the VA, so we both put into it and we can both pull out of it. And so far, we've developed a charter and had a series of meetings to discuss the art of the possible on the data and analytics. And it's very exciting. We do not have any results from it yet, but the framework is in place, and a number of discussions have been held, particularly in the context of predictive analytics.
Can you go deeper into that, and perhaps anyone else who's with you at the panel? What are you seeing correlations with combat, with specific kinds of combat, specific experiences within combat, correlated to higher likelihood of suicide attempt?
Those are precisely the things that we're going to begin looking at. The database was just stood up. We've only recently put the business rules in place and put in a series of processes for folks to access the data, to begin to look at the research questions and going through proper IRB procedures and those sorts of things. So it's in its early stages, but there is quite a bit of excitement about the potential future of it. So far, what we've also done is discussed opening up to academic sector and letting folks know our research needs and our gaps so that folks can tap into the database and help us study these very issues. I wish I had more for you in the context of specifics on the analytics, and I hope to at another time, potentially even another hearing.
I look forward to that. And General McConville, you mentioned identifying risk factors and then acting upon those. Any that I just mentioned right now, are those correlated, or are those risk factors that you're looking at, combat service, particular kinds of combat
We have,
service?
and one of the value of the massive STARS study was it's really not as combat related as some would think, and you know, as we went through this, the folks that are most likely to commit or most likely to die of suicide are those that have 0 or 1 deployments. It's not the multiple deployers, which we were kind of, you know, it's counterintuitive to what a lot of us thought, and that was, you know, again, a very, you know, and we're continuing to look at that. Doesn't mean that combat 1 deployment does not affect you, but it does get back to those that may have some type of behavioral health issues going into the military. That's very, very important. And as we move to a complex behavior module, it's more than one effect. The fact that someone goes through a divorce does not mean they're going to die of suicide. The fact that someone has a drinking problem does not mean all those, but it's getting those compact factors coming together and then understanding how they affect, because they affect all very differently. The thing we're trying to get to is really trying to measure resilience. And this is, it's not like on the positive side, you know, when we bring soldiers in, resilience or grit is something we're trying to define in our screening process. So someone comes in, we know what a resilient person is. We've always focused on physically fit, but we're also focusing on mentally fit, and we're also focusing on character, because those are the attributes that we're trying to bring in to the service. And then once we get them in, is to give them the type of training they need when they're brand new soldiers in initial missile training and during that first period of time. Because what we see is, if we look at suicide attempts, and what our studies have shown us, actually it's female soldiers are most likely, first-term soldiers, to attempt suicide. Brand new soldiers, male soldiers are most likely to die of suicide during their first term. So that first term is very, very important, the first couple of years when a soldier comes in, because we really haven't fully brought them into the culture of the military. And this goes with a lot of things, with sexual harassment, sexual assault. All those things tend to happen, the higher percentage, in that 1 or 2 first-year soldiers. And that's why we're really focusing on this Not in My Squad campaign that we're going after.
Thank you for your answers. I'm going to have to yield back to the chairman. I appreciate the indulgence.
Mr. Kaufman.
Thank you, Mr. Chairman. First of all, I want to commend the Army, and I don't know if the other services are doing it too, in terms of recruiting and now trying to develop methodologies to determine who is more resilient than others, who is more likely to fall victim to the stressors of training, of combat training, of deployment, of all the things in the military. And so I think that's very important if we can mitigate problems through the intake process in terms of who comes in. One thing I wanted to ask all of you is that what is different? If I look at my service in the first Gulf War and my service in the Iraq War, later on in 2005, 2006 in Iraq, that in the first Gulf War you were just checked out. It was probably the last war where there wasn't the internet, where you just, you know, it was snail mail, you checked out, you went there, you came back. You didn't have communications with your family until post-conflict, then occasionally on a landline or a phone. But where in the Iraq War, where you have, and Afghanistan too, where you have forward operating base, and you have soldiers, Marines, and sometimes airmen and sailors going outside the wire, coming back in, getting in real time with their families being told, you know, we're having these problems and these problems. And so all of a sudden they have the compounding effect of being concerned about what's going on at home in real time and being deployed in a combat zone. How much is that, how much are those stressors factors in suicide rates? And the fact that we have fewer deployed troops today, does that bring it down? Although we have a lot of deployed troops just not in a combat zone, but all over the world. Who can comment on that?
Sure, I guess
Sure.
I can comment. Really, I think you bring up a great point. And as I look and try to put this in perspective of the strategy that we have is, you know, when we were going to the Gulf War and we were doing that before,
Sure.
there was no contact. Now, the soldier's sitting there, he or she is Skyping with their significant other. And, I mean, I could give you some horror stories of some of the things that happen while people are Skyping and things that have been said. So that creates a tremendous amount of stress on our soldiers, because we look at some of the factors. We're saying, okay, so relationships is a problem, financial is a problem. Well, they have a direct access to that soldier to do that. So that is a significant concern as we go forward. And again, that's why we want to build the resilience, both in the soldiers but also the families. And one thing that we really haven't talked about is our resilience training for families. And right now we're training master resilience trainers. Sure. The spouses have taken that on. They are more ecstatic, and and they're excited about that. That is making a difference. So much so that we're standing up a program for our teens too, and because they want it. And again, anyone that's had, as you know, have military kids traveling around with the stress of the military, very, very important for our folks.
This is one of the prime factors that led us to start training family members as resilience training assistants, because the connectivity back home, while comforting in many cases, it can also share the stress that from what's happening in the operational environment. And so we recognize the importance of having key spouse programs and actually incorporating resilience training into the key spouse program, which led us to do that. I think in terms of the members who are actually deployed, we've actually found that our suicide rates among airmen during the time they're deployed are far lower. And we think that's because of the sense of responsibility to their fellow airmen, and they're part of a team, and they understand that they've got a responsibility to be there for their team. And so during the actual deployment, we found that the rates of suicide attempts are far lower.
Three parts of your question. I think, is there a link to combat and deployment? We have not found any in the Marine Corps, similar to the Army experience and the Air Force experience. It is a factor, but it's one of many, and typically suicide is related to 10 to 20 of those in any given case. Sometimes it is, but more often than not, in the past year, it wasn't deployment or combat. We are looking at screening very hard. Part of our Marine Corps Recruiting Command effort, a very deliberate effort to look at what screening would be the most effective up front before a Marine comes in. And we use a Marine total fitness model to look at body, mind, and spirit and social. And finally, we are also training families through a new Conquering Stress with Strength program that we initiated this past year. It's fairly new, but it's been well received, and we expect to expand that across the Marine Corps.
The Navy has similar results where we have not found that deployments has been significantly related to deaths by suicide.
Thank you, Mr. Chairman. Thank you, Mr. Chairman. I yield back.
Thanks. Mr. Waltz?
Thank you, Chairman and Ranking Member. I want to thank each of you for the work you've done. It's gratifying to me to see the commitment is here, and I know of going out and talking to folks over the years and having wore the uniform within the last 10 years. This is not a box to check, obviously, for the services. This is a commitment that is deeply ingrained in the culture, and for that I am incredibly grateful. It is a very difficult task to take on. It's one we understand we have more responsibility to, but it's a readiness responsibility, as we all know. This is force multiplier and keeping people healthy, and I think the resiliency training, I would make the case that once again, you are probably outstripping the private sector, and this issue of mental health parity is still a troubling thing, stigma in the private sector. We work very hard to get insurance to pay for it in some cases until very recently. So I understand the challenges, and I also think, you know, all of us hear this. It's amazing to me. And people want to fix this badly, and they want a fairly easy fix. And I remember we worked really hard in the VA, and earlier this year, we passed the Clay Hunt bill. And I was gratified to see that happen, but I said if you needed a stark reminder of this, in my hometown of Mankato, Minnesota, the day we passed it, the next day on the paper, the top half of the paper said, Clay Hunt bill passes Congress. The bottom half of the front page was a young man walked into the Minnesota State University Mankato Library and died by suicide, gunshot wound in there on that very same day. And so it reminds me that this is deep dive. We're in it for the long haul. There are many factors. The research is catching up or starting to, and I am grateful for where you're going. And I think that leads to me, I'm not going to ask in detail. This is just my hunch on this. I think the spirit that I've seen this be taken on is real. It's happening. And so when I see the IG was talking about unsynchronized, I think that's pretty much a condemnation of our entire mental health system, if you will. And so I'm not sure if there's any question to ask there, if you agree with where they're at, or if there's something we can do. I read that and they read it, and perhaps we should be more concerned, but it strikes me as perhaps this is deeper. I don't know. Maybe starting with you, Dr. Franklin, and also I'm grateful for your office proactively reaching out soon after you were in your job and working with us, because we're unsynchronized with the VA, if you will, and you were working to try and make that happen.
Yes, thank you so much. Good question. And the unique part of this challenge is at the DoD level is putting the standards in place, making sure we have the best research and opportunities for the services to work together. And the department really serves in a facilitator role in some regards, bringing some synergy to the table so that the services learn from one another. But at the same time, I couldn't agree with you more in the context of the services needing to have service unique and specific programming where relevant, provided that it meets the standard and that it is the best. And the best that we know from the science. So honoring the service uniqueness, having worked as a social worker for the Army and the Air Force and at the headquarters level for the Marine Corps, I can tell you that they're quite similar but also quite different, as you probably well know.
Yeah, and I hear listening to folks talk, and I think that's important. So I think, it's important for us to publicly address that. I appreciate the IG pointing this out, but I think there is more to this than what the report said. So the next thing is part of that, and I heard each of you say this, and General McConville, you mentioned this peer-to-peer piece or whatever. We did best practices on Clay Hunt and showed there's a lot of success there. We're kind of looking outside the governmental things. Different organizations, one I'm partial to, Ride for Recovery, and some of these, of how do we use these with evidence-based programs that are making a difference. How do we synchronize across these? Because they've got their own issues inside the world of the Army, the Marines, and so forth. And I don't know if any of you want to tackle that, or maybe this is to you again, Dr. Franklin, of how do we use those external resources?
External resources, in some sense, even from the VA and also from just sort of what I say outside the gates resources. Certainly, we come up with a number of good ideas by looking at best practices with other population groups, whether we study police officers or firefighters. There are evidence-based practices that can be applied right inside the DoD. And part of that is hearing about them, learning about them. I've taken a number of briefs myself on these practices, trying to stay current. At our quarterly council meeting, we bring in experts from outside industry. Most recently, the American Association of Suicidology came in and briefed. The Coast Guard has come in and briefed a number of best practices. And then from there, the relationships are in place for folks to gain more information and further discovery and determine how that particular practice might fit within their service.
Well, I'm glad to hear that, because I think what I hope you need to know is, in the VA, we talked about this is all of our issues, all Americans. Yes. We need to pull in every resource, and you're doing all you can, but if there's things we can do, we need to make that as available as possible. So thank you, Chairman.
Thank you. Dr. Franklin, last year, and I know you're new into the position, and I appreciate you with your office call that you had a few weeks back. We talked a little bit about metrics and effectiveness and measures, but the question I have for you specifically now is, last year Congress required DoD to develop a policy to collect data on suicide attempts involving members of the armed forces and deaths of military family members that are reported as suicides. It's my understanding that the policy is still being developed. So when can we expect to see that policy?
You're absolutely right. The policy is in progress, and it should be done by now. I agree with you, and if folks on the panel are frustrated, as am I, we need to move this policy along sooner rather than later. It's an important policy, and looking at the family member data piece intuitively makes sense. It's the right thing to do. I wish I could give you an exact date, but just know that it's one of the top priorities on my list right now, and I'm working it hard, as is our entire P&R leadership chain.
Can you ballpark it? Maybe not an exact date?
I would say February 2015, and my Ledge Affairs person behind me is probably not appreciating me giving that date, but I'm trying to get it done sooner.
All right.
Sooner rather than later, and definitely, I could, like I say, I couldn't agree with you more. The good news about this policy is that all the services have met. They've agreed upon a standardized approach. Actually, the Army led that group. I couldn't have been more pleased with them for that. And so methodologically, the process has been staffed and looked at and studied, and I feel confident that when you get the data, there will be an increased level of fidelity, in part because of the length of time that it's took to put the plan together. But again, it needs to move.
Great. I appreciate you making that a priority. You know, all of you talked about the importance of the first line leader, the squad leader, and being the person to identify at the lowest possible level somebody who may be at risk. And I certainly agree. And I know it's very hard to prove the negative, to prove the thing that didn't happen. But how are you measuring whether or not the programs you have that are training the frontline leaders actually effective in decreasing suicide attempts? I can tell you that, again, in personal experience, I had a squad leader, had been through all the training, the ACE training. It was actually a master resilience trainer, and was out with one of his squad members on a Friday night. 2 hours later, after he dropped that squad member off, the squad member died of suicide. And so the question is, how do we know that the programs that we have are actually effective in giving the tools necessary to those first-line leaders? And I'm going to start with Admiral Burkhart, because we've been starting this way, and you've been awfully quiet. So we'll start this way and go in reverse order.
Yes, thank you, sir. I think one of the things we've noticed with our bystander intervention and helping sailors know that it is every sailor every day, and that their responsibility to step up and step in. And that's resonated with that peer-to-peer training and the dialogue and the methodology that we've been rolling out our training and our awareness. The sailors are engaged and they want to make a difference. I think the struggle is connecting the dots. So a lot of different, whether it's a family member or the unit, or one of the programs that the member has been engaged in, like financial counseling, or if they've been going through administrative or legal separation processing or transitions from duty stations, is that we have a way to make sure that there's warm handoffs between programs, and also that we're keeping in touch with that sailor to recognize the change. Where I've seen a lot of difference between the suicide ideations, and that the sailors are sharing with their shipmates, and the shipmates are bringing it to attention and referring the sailor to the proper resource. And I see that quite often in the reports I receive, that it's happening, whether that referral is to a shipmate or to the chain of command, or it's a family member that's bringing it to the attention of the chain of command, or the chaplain. And the chaplain will really focus on a strategy to make that confidentiality applies to the service member, and making an concentrated effort to say that also applies to the family member. And it can make a difference where the family member may have a perceived or real perception that if they bring something forward to the Navy, that there could be hurting the member's career.
Great. Thank you.
Yes, sir.
General Whitman?
Yes, sir. It is hard to prove a negative, of course, but we too track each individual story. I mentioned one in my opening report, and we do have a number of those where we can at least see that in that case, at that moment, we saved a life. We have a more robust now annual training program for our Marines called Marine Awareness and Prevention Integrated Training. Every Marine goes through this every year, and it includes elements of identifying risk factors, triggering events, warning signs, protective factors. I have tested this when I've gone to visit units, and Marines can read back to me what they have learned. So again, anecdotally, I think it's making a difference. They know, and you can trace back that training to some of these individual cases for peers and for the direct leaders with those Marines.
Great. Thank you. My time has expired. Ms. Spear?
Mr. Chairman, thank you, and thank you for holding this very important hearing, and thank all of you for being here. I've been rattling around in my head the New York Times Magazine story just a few weeks ago. I mean, I just can't get the pictures of some of those tragic stories out of my mind, and I hope all of you, I see that Rear Admiral is nodding her head, she's read it. I don't know if all of you have read it. If you haven't, I really commend you to read it, because while it talks about the suicide rates among veterans, it raises a lot of questions. And one of the earlier questions by one of my colleagues was about whether we are tracking combat versus stateside and the like. And I get the impression that you don't see any difference in terms of the suicide rate between those that actually serve in active combat and those who are not in a combat setting. They raised that question in that article. And I don't know, I guess the question is, do you track that?
Absolutely. This is tracked through the DODSR suicide event reporting tool. It's tracked whether the...
And you see no difference, basically.
There was recently an article published in the Journal of New England Medicine. The title of the article is something to the effect of deployment is not a singular risk factor when it comes to suicide. The issue is you often have to unpack that variable of deployment. Not only have they deployed, how many times, what was the length of their deployment, what was their level of combat exposure while they were on that deployment, and what was their pre-existing trauma, perhaps that they've experienced before they even went into the war zone. So it starts to get complicated very quickly. Also, what protective factors did they have in place if they had had pre-existing trauma or not? I struggle when we try to narrow it down to just two simple variables: deployment, suicide. It's really not that simple. The issue around suicide that a lot of the folks on the panel...
Well, excuse me a minute, Doctor, I've got limited time.
Yes.
So do we think that possibly multiple deployments may have an impact in the higher incidence of suicide? You don't know that either?
It's not what the data is telling us.
Okay.
No, ma'am.
That's fine. Okay. Let me ask this question. In that same article, there was a reference to one vet who went to seek help, spoke to a counselor, and the counselor said to him, you've got to think about this as a breakup, like a breakup with a woman. And you've got to think of it in those terms and move on with your life. And I thought to myself, we've got serious problems if we have healthcare professionals providing services to persons with mental health issues, talking to them in those kinds of terms. So it raises the question, what are the qualifications of those who are counseling persons that have mental health issues who are active duty military?
I can speak to that. So across all three services, we have common standards in terms of the credentials that are required in order to gain.
And they are?
Privileges. Well, for licensed clinical social workers, there's a licensure in one of the states of the union, and they must be certified as a licensed clinical social workers. For our psychologists, we privilege them at the PhD level for our clinical psychologists across the three services, and of course psychiatrists residency trained in a program approved by the ACGME, which is the organization in the U.S. that does that.
So a clinical social worker could in fact be counseling someone who's suicidal?
Yes, and they are trained to do that.
Okay. So have we kind of reviewed the qualifications of those who provide those services and see success versus non-success? I mean, maybe that's not something we can do, but it certainly would be interesting to see if there's a certain level of educational attainment and experience that is most effective in assisting someone who's got suicidal tendencies.
And so in the military health system, we have a scope of practice that's specifically defined for each individual provider, and that is tailored to their certification and their specialty. And so each commander of each medical unit specifically privileges the provider to provide certain elements of mental health care. And so a licensed clinical social worker knows full well what privileges they hold, and they're qualified and cleared to services to perform. And then if they recognize that a patient needs care that goes beyond their scope of practice, then they refer them to a higher level of care. To a clinical psychologist or a psychiatrist, as the case may be, or perhaps refer them for residential or inpatient care. And so this is all monitored through a quality assurance process that's defined in a DoD instruction.
Mr. Chairman, could I have one more question?
We're going around for a second round, so hopefully we'll get to you. Ms. Davis?
Go ahead.
Okay. Ms. Davis will yield.
Go ahead.
Thank you. I thank you for yielding. I have one question, one comment. The use of psychotropic drugs with persons that have suicidal tendencies, I'm sure is used a great deal. Have you tracked those who have committed suicide as to whether or not they have taken their lives with drugs or by use of firearms? And what has that told you? What have you learned from that?
We do. In regards to firearms at the DoD level, we actually have statistics, and that is the most frequent means of committing suicide among service members across all three services. And that's true of males nationally in the U.S. as well. In regards to mental health care, we do actually track, and we know which of the service members that commit suicide were under mental health care within 90 days, in our case, of the time they committed suicide. Each of those cases is individually reviewed. And we have a lot of service members that receive mental health care month to month. I know in the Air Force, we have 230,000 mental health visits a year across it. And of course, the rate at which those mental health patients commit suicide is well below, 0.01%. But everyone that does commit suicide who is under some kind of mental health care, both Army, Navy, and Air Force, is reviewed to determine if there's something we can learn from that. And I can tell you, in many cases, those patients had encounters with mental health, but actually, even though at every visit we have a standard that we require a suicidal risk assessment, in many cases, those patients never expressed an intent or a desire to commit suicide during their mental health visit.
I thank the gentlelady for yielding. I yield back.
Thank you. What are the, you all talked about the resilience and trying to build that in with families. And I have some dear friends, and it's kind of an amazing case that's been followed by a lot of people because their son had enough going for him to write a very extensive suicide note. And one of the issues for them was whether or not there would have been the ability to someone contact them that their son was having such difficulty. We have many safeguards in terms of confidentiality, and I respect all of those. But are there some tools in working with this? And I was trying to go through as well with the IG's report. I didn't see them making any specific recommendations. Obviously, we're concerned about confidentiality on a number of different levels. But families want to be there for their loved one, and often they have no idea. Are there some ways that you're seeing that can perhaps be, someone would have the ability to sign off on permission? And I would see this even as early as a recruitment phase, that while you're educating families and parents and the service member, I don't know, how do we do that? Because I think we would prevent more problems if families had the knowledge.
Yes, and thank you, Rep. Davis, for sending that family to me. I had a wonderful afternoon with them, and I really appreciated the opportunity that you provided in terms of hooking us up, and I appreciated the special time that I had with them to hear their unique story. And I gave them, I could see their story transferable across multiple other stories, and so I was thankful that they highlighted it and brought it forward, because I think that could be a practice, and I gave them my commitment to look into that further, this notion of a listserv, or perhaps some education and outreach to parents of young service members that would educate the parents on just military life in general. Being a part of this culture for my entire life, some things we take for granted about the culture that we know because we've always known them. And that family and many others like them could greatly benefit just from some education and some awareness in a way that doesn't impact the confidentiality that you mentioned. Thank you so much.
Mm-hmm. Thank you.
Mr. MacArthur?
I recognize your primary focus is on prevention, as it should be, and I respect you for that. I have a question for General McConville, and it has more to do with the impact of these suicides on others and its effect on military readiness. And you noted earlier that there's a higher suicide rate among those with fewer deployments, which is surprising, I guess, to me. And you suggested that the possibility, maybe even the likelihood, that this is related to pre-existing conditions when people enter service. And I wondered, are your findings making their way to the recruitment process? Things like resiliency, are you looking at indicators and putting that into recruitment, or is it too unformed yet, the conclusions for that to have happened?
Thank you for the question, sir. No, where we are right now is this notion of measuring resiliency, because we want to prevent suicides. But what we really want to do is we want to build these incredibly high-quality soldiers that can go out on the battlefield and do the things that we need to do for the country. So what we're using, we have the Army Research Institute that works for us. It's social scientists. That's what they do for a living. And what we're trying to do is take terms like resilience and say, okay, how do you actually test someone? We have tests that we do right now when soldiers come in. They take, other than the standard type test, we call it TAPIS, where we try to get an idea of how sound they are. But we're trying to refine that science.
But does that imply, because I'm inferring that you've concluded that lack of resilience is a possible precondition, something that predisposes somebody to taking their own life?
Well, what we've found, at least from the Army perspective, is we were doing what I would call a lot of diving catches, and my Marine colleague talked about that, is how we all of a sudden had a soldier in serious, and we basically saved his life. We have lots of stories, Marines, all of us have. So that's one part of it, but what you want to do is kind of move away from that. What we're trying to do is move the whole force really away from what the red area. I call the diving catch the red area. We move to a yellow area where we start to manage and identify these transitions or these high risk factors that we're training our soldiers to do. We move them even further where they're really in a resilience phase, where we build soldiers who can handle stress, who can handle adversity. If they have behavioral health type issues, they're getting that early on, just like if you had knee injuries or physical type injuries.
Yes, and my question is, take your knee injury. There's a certain degree of physical incapacity that would render someone unfit for military duty.
Right.
Are you taking some of these findings regarding resilience and other things that I think you're suggesting may be precursors or things that cause somebody to be more tending towards that? Are they coming into the recruitment process? Are you looking at resiliency or brittleness, maybe the opposite, in personality testing to see whether someone raises a red flag at the recruitment? Or is it, again, or is it too unfounded yet and would actually be discriminatory? I'm trying to get a sense of whether you've closed the loop on the recruitment side.
Yeah, what we're trying to do is we're trying to find that sweet spot, because we don't want to, for folks that have sought treatment, to say, hey, you can't serve. You know, we're trying to find, I mean, just like some other type of injury, we want to give everyone the opportunity to serve that can meet the standards and is mentally fit enough to do that. So we don't want to have arbitrary, if you've had some type of behavioral health counseling, if you saw a high school counselor. So the challenge we have right now, and I've asked I'm not a scientist, I'm a helicopter pilot by trade, but what we're trying to do is get the science to help us do that, where it's a fair type assessment, where we can screen and look at that. Part of the STARS study was to try to find that. We're not there yet in science, and we'd like to get there because we think that would be helpful for everyone involved if we could screen to a level where we identify, like we could do with a lot of the physical type injuries.
I would just add in my few remaining seconds, I'm not faulting you for that. I think it could be a slippery slope, but I am interested in, as we come to conclusive findings, where they make their way into our practices in the military. That I think could be helpful. I yield back.
Mr. O'Rourke?
Mr. Chairman, I just want to thank those who testified today. I learned a lot at today's hearing, and some of the facts that you gave us were counterintuitive to my assumptions about where we should be looking and where we see risk. But I do think, Dr. Franklin, that we do need to see the analysis that you talked about, and we do need to better understand the measures for success and hold ourselves and you accountable for that going forward. And I am very interested in understanding how we apply what we learned here or within the Department of Defense to taking care of veterans who may be at higher risk for death by suicide. So thank you all for what you're doing. Thank you, Mr. Chairman.
Mr. Waltz? Ms. Spear? Okay, again, I thank you all very much for being here today and offering your testimony. We all stand ready to assist you in whatever way possible as we try to erase this scourge of suicide within our military. This hearing's adjourned.